My name is Dr. Emma Spencer and I am a member of the Trainees and Members Committee at the Royal College of Physicians of Edinburgh. And today joining us is Prof Mahmood Adil. He's worked as a medical director and worked for Public Health Scotland and clinically as a paediatric diabetologist. He's a clinical informatician appointed by the college as the first ever clinical data and digital health lead. Today we'll be talking a little bit about what that role might entail, his career to date, and how he feels these areas might be relevant to the general medical trainee. So welcome, Prof Adil.
Thank you, Emma, and I'm grateful having me on this podcast.
With your role with the RCPE College Lead for Clinical Data and Digital Health and your roles you've done in other organisations, can you tell us a little bit about what those roles might entail?
Well, I think it depends on the role. For example, when I was medical director for Public Health Scotland, Public Health Scotland is the organization which collects all the health and care data in Scotland. So it means that it has got a huge advantage of having a data of 5.4 million people. And it means anyone who is working in Public Health Scotland, in particular in professional leadership role, you're keen to use that data and change into health intelligence to give insight. And that was my role while I was at Public Health Scotland, that how best we can change this data for our clinicians, for our policymakers, for our managers, and for our patients, so that they can use it and make their health better, or we can deliver better services. But then I remember I had a good conversation then with the president of the Royal College, Derek, and I said to him, look, so many people are coming to Public Health Scotland, my colleagues, the clinicians, that they're saying how best we can use this data for clinical purposes in more effective manner. Why don't we create a role within the college which could be much closer to our fellows and members? And that's the reason this role was created. But what does this role entail from college perspective? The first thing I was very keen and still very keen to do is to raise the awareness of data and digital, because our clinicians need to be very clear what is meant by health data and what is meant by digital health. And just to recap, and I'm sure if you go on the website of the college, we have done 2 wonderful videos which explain what is health data and what is digital health. And I would encourage that anyone who's listening, they should go. It is only 7 minutes, a bite-sized video. But let me recap that what we are very keen to do in the college, to be very clear that when we say health data, it is not the clinical data you collect through your patient interaction in the hospital. So health data fall into 4 groups. First is clinical data, of course, the lab data and everything else. Second is the lifestyle data, which now we started collecting. So many countries, in particular, the Nordic countries, they're very, very good. And the third one is the omics data, the genomics, proteomics, and so many omics data. And this omics data is becoming almost routine. And the fourth one, which is, in my view, is the most important, is the social determinants of health data. Because 70% of the outcome of the disease or outcome of the health of the person or health of a nation is dependent on the social determinants of health. And in Scotland, we divided the country into almost 10,000 data zones, and we collect data in each and every data zone. And this is the same state of play in England as well. So I think this is the data side. For digital health side, I want to be very honest that people use the digital health terms in a very, very different way.
Yeah.
But the question comes, what is digital health? If someone asks, and what would be my answer or your answer? It is the use of information and communication technology in support of health and health-related field. And of course, as time went by, artificial intelligence came on board, big data, blockchain, so many other new technologies. They all come under the remit of information and communication technology. And with that clarity, I would say that digital health is the field of knowledge and practice associated with the development and use of digital technologies to improve health and healthcare delivery. So it is a field of knowledge and practice. And this is the way my colleagues from US has honed it. because they wanted to make it a separate specialty. And there is a number of reasons that before we start thinking, can we make it a separate specialty in UK? But the point is that this is a very important field. And now raising awareness is first the most important thing, what we did in the last few years within the college. As you might have seen, as I said, those videos were created, conferences, the evening updates. Wherever I got the opportunities, I did my best to raise the awareness. And the second thing about the data and digital literacy, because this is, again, key thing that, yes, you can raise the awareness, but what is the purpose? So that brings me to the question that when we say the digital literacy, what does it mean? It means your ability to access, understand, and use the digital tools. Let me repeat it. Your ability to access, understand, and use. So we are very lucky in the NHS. A lot of things have been done, for example, by NICE. They say these are the digital tools which could be used safely and effectively. FDA in the past, in America, they have approved a number of digital tools. But the question is, have you got the ability to access them, second, to understand them, and the third, to use them? And I think this is something the college and we within the college are very, very keen to do. And the third thing which is important in this role is show the example of best practice. Because to make things tangible, that how it is going to make a difference for my patient, it is very important the clinician needs to know. I should show them the example. College and other organizations should show them the example, how the things can be done in reality.
That was a perfect answer and leads so nicely on to our next questions, because I was going to ask you exactly what you'd want that term digital health literacy to mean to a resident doctor. And it sounds like, you've already summarized that, and there's some amazing videos online that people could go to if they wanted to watch an explanation again. Maybe you could also give us a bit of an idea of how a clinician could enhance their digital health literacy or get better at using, understanding, and accessing those tools.
Yeah, excellent. If I go back to my clinical days and I'm sitting an outpatient or I'm doing a hospital ward round, what are the things expected from me as a physician, both from my colleagues as well as from my patients? I think it is expected I should be delivering effective care, safe care, patient-friendly care, and efficient care. So if these are the four purposes of my day, I've been trained over the years, then the question comes, what knowledge and experience I need to gain for digital health to make myself an effective doctor, a safe doctor, a patient-friendly doctor, and an efficient doctor. So I always say that there are two ways to deal with this challenge. First, you need to be motivated, right? You need to be very clear that, yes, really, I want to do it. And the reason you need to be motivated, whether we like it or not, digital health is the future. You can see that in your trust, they're using Epic, and the many other organizations, they're bringing very, very potent EMRs, but they're only potent as long as you can use them effectively. Coming back, that's how you could be effective. It means you can deliver care which can improve the patient outcomes. Let me start. There are many different tools available. First are the clinical decision support tools. Have you heard of Open Evidence?
Yes, I actually downloaded the app this week because someone told me about it at work. Yeah.
Oh, wonderful. Okay, so let me use that example. So there is another app which is called medwise.ai. Exactly work on the similar premises. You get a question or you have a patient and it's complex. You cannot go back to so many nice guidelines, or you cannot go back to many things you need to look at. You put the information in and it can give you the answer if you have tried open evidence in such a way so that it is going to make your life and the interaction with the patient very easy and very effective. So this is what I learned, that if my clinical colleagues started using those tools, in their day in and day out, it means they can save time and their health outcomes would be better. If I had the opportunity to present, which I think I presented a couple of years back at the Royal College conference, then I usually showcase it. That here is a patient with these sort of comorbidities. These are the medication the person is on and all the social parameters, and then see what results you can get. And then you will see it will give you the answers much easy. You can digest it and it's evidence-based. Then the second thing, thinking about how you can learn. Either you can go by knowledge-based approach or experience-based approach. It depends which organization you're working in. Let me give you one example. My understanding is Great Ormond Street in London, they have started ambient speech in the whole trust. It means when you're having interaction with your patient, everything is getting recorded and it goes into the patient record directly. It will save you a lot of time. So it means if these tools are available, you need to have the courage to start using them. So this is one way of how you can learn with experience. Other is the knowledge based. Now, if you go on Moodle, if you go other platforms, there are very 15 to 20 minutes programs which you can go, not the AI programs. It's a program which has been created so that you can learn the ABC of the digital health tools. So I would say first you need to have the motivation. Second, you need to think where you are based. Then you can ask your hospital and trust that you're very, very keen. And then third thing is that do it by experience. And the fourth one, if you have time, it's better to have the basics sorted and go on those Moodle courses.
Absolutely. I'm sure there's lots of our listeners that know that this will be a part of our future in healthcare and want to get more knowledge. So that's some great signposting to where they can. And my homework is to start using open evidence now, which will be exciting. I wanted to maybe ask you to give one example of how you can see improved digital health literacy impact directly on patient care. I know you've talked about a few throughout your chat there, but just maybe a specific one you'd want to raise to people.
Okay. If you're happy, I can use diabetes as an example.
Always, yeah.
Right, because we have about 5.4% prevalence of patients with diabetes in Scotland. So what you need for a patient who has got diabetes, you want that the patients, nowadays diabetes is not a disease. It means that if you have a disciplined patient, you can treat the patient in the right way. The patient live as healthy life as any other individual. And the complications of diabetes can get delayed, or even chances are they may not get those complications. But the question comes that what are the tools we have in hand, the digital health tools, which can help us to achieve that goal? So in Scotland, we have got the data called Sky Diabetes. It's all the data with patients with diabetes in one place. Then they have developed the tool called My Diabetes My Way. This is the app which any patient with diabetes can download and can see that what control he or she has on diabetes. Plus, it can guide the patient that how best you can improve your own outcomes. So there are a number of tools being approved by FDA, and these apps are available because we need to remember that with chronic diseases, we try to co-create health. It is not like surgery that being a surgeon, I can do the appendectomy and 90% onus is on me because I and my team need to do the right surgery to take the acute appendicitis out. In chronic disease management, it is a multifactorial, and we need to make patient our partner, and we need to empower patient, and digital health does empower patient. The role for our clinical colleagues are when you do your consultation, you need to ask the patient, do you use any digital health tools? Are you wearing any Apple Watch or any other thing which is collecting a lot of parameters? By asking that question, you remember when I was trained, I was told that in history, you need to take these pieces of information from the patient, including social history. Now the time has come that we need to tell our current and future graduates that they need to ask about the digital health history.
Yeah.
That what tools you are using or you are keen to use, because you can check the aptitude of the patient. So coming back to diabetes. So in this way, this is one way. Now, on the other side, if you go by the type 1 diabetes, where your patient is on insulin, and I dealt many of those in my career over the years, is that we need to use the monitors because we are giving them insulin through monitors. And now the algorithm of giving them the right combination of insulin at the right time is becoming much easier because the computer and those algorithms can be calculated in the background, and you do not need to be doing it as a physician spending a lot of time. And the third thing is that, which I feel, which is the public health and prevention side, we need to be thinking in terms of diabetes. What are the things we can do and we can help the patient or the people who are going to be the patient, how best we can improve the health outcome of the nation. And this is what we have done. Many countries have done. For example, in England, they developed the Atlas of Variation. So when I was in Scotland, we learned a lot. I mean, I'm still using Scotland, England, but it means our difference in healthcare system is wonderful because we learn from each other.
Yeah.
So in England, they developed Atlas of Variation on the complication of the diabetes. And we learned that how best we can do these things in Scotland. So it means we can think at the population level, why, when we have got standardized data, some part of the country is not getting a standardized care and they're having more amputation because the diabetes is not well controlled. And then, of course, you need to work with the diabetologists and the clinicians that what are the things they are not doing in order to improve patient outcome. So again, I use the diabetes as an example where you can use the data and digital health in order to improve the patient outcomes and make your services more effective.
Yeah, I think that's really interesting. I think those tools on an individual level are amazing to empower patients in chronic diseases, as you talked about. But maybe I don't think as much about how, from a bigger picture public health perspective, you could look at what's different in different areas and how you can intervene there. Wanted to ask you a bit about maybe what's the thing you're most excited about in the future of the NHS with digital health literacy, and maybe what you see as the biggest challenge for the NHS, because there are undoubtedly challenges in using these kind of tools.
I think first of all, we all should be proud of the National Health Service. It was, of course, established in 1948 on 5th of July. Every year we celebrate the birthday of the NHS. But the system is wonderful on many fronts. First, it is clinical based, so you are treated on the basis of your clinical need. It is free at the point of delivery. And it is outcome driven. It is keen to improve the patient outcomes. And now we do collect a lot of data in the NHS. So NHS does collect a lot of data. At one point, there was a cliche we use. It is a data rich, intelligence poor, that we collect a lot of data, but we don't use it effectively. So the opportunity NHS has created is that it is collecting a lot of data on individual patients and on populations. But now we need to find the ways to change it into health intelligence, which we can provide to our frontline clinicians, we can provide to policymakers, and we can provide to patients and populations so that we can improve the health of the nation. And I think this is what I see the biggest opportunity. Now, having data itself is not good enough. Now AI is coming. There was a time when we say, okay, I can collect a lot of data, and then my data analysts could change and help me to change into intelligence. Now, with the availability of most of the AI tools, which you and I have got access to from ChatGPT and a number of others, we can ourselves change that data into very much applied intelligence relevant to my patient and to your patient. Then the challenge comes, patient confidentiality. What data I can use in order to improve my patient outcomes into those AI tools. And this means we need to raise the awareness of the information governance, patient confidentiality. You know, there are two main big concepts concepts in information governance. First one is primary use of data, and second is secondary use of data. Primary use of data means that your data is used for providing you direct care. It means no one need to have your permission to use that data. Otherwise, you and I and any other doctor who's providing services wouldn't be able to provide any services. So by law, it means, but secondary use of data means that the data is going to be used for research, for innovation, for policy, other things. And this is where we need to be very, very clear. So I feel that my clinical colleagues and the new graduates, they need to have a good understanding about the information governance so that we can use patient data in the right way to achieve the right outcome. And the challenge, I mean, this is the opportunity. We have a lot of data and we can use it to improve our patient outcome and population health outcome. The challenge comes that, first of all, you need to have the understanding, going back to the data and digital literacy. If we don't include in our curriculums and the medical schools and the postgraduate curriculums, the competencies, if I use the word, then the chances are that we will have a lot of data and our clinicians won't be using them effectively because they are not data and digital literate. And we can only make them and we can improve their competencies if we can include it in the undergraduate and postgraduate curriculum. So this is, you are in part of education and training within the Royal College. This is very important. We need to be looking from that perspective. Second, people are very concerned AI. So AI is being used everywhere. And there are two schools of thoughts that I can use the AI and I can trust it. And the second school of thought is, no, I do not want to use AI because I don't trust it. And I personally feel that we as clinicians need to work together to identify the reasons why we don't trust the AI use in healthcare. And we need to overcome those challenges because at this point in time, Academy of Medical Royal College is now making an effort that how best we can have a unanimous voice and to understand, to explore the trust issue and all other issues, because data leads to AI and AI will lead to improve health outcomes. And I think we need to be making sure that as professionals, we understand it and then we do our best to contribute it accordingly.
Yeah, I think the development of AI in healthcare will be fascinating and is just undoubtedly already in our, already existing in our day-to-day lives and will be more so. So it'd be really interesting to think more about how we incorporate it and how we get trusting and use it well. When I was preparing for this, I was having a read about you online and I just noticed one other really interesting thing you've done with your career, which was from a public health point of view, be involved in Olympic Games and Commonwealth Games. I wondered if you'd talk very briefly about what you did there. I just thought that might be of interest to some of our listeners.
Well, it says that sometimes opportunity knock on your door and you need to grab it. And this is what happened in 2002 Commonwealth Games in Manchester. I was head of health protection and clinical services for Northwest of England, working with the Department of Health. And when Manchester won the bid to have the Manchester 2002 Commonwealth Games, I was given the responsibility to look at the emergency planning and look at are we clinically prepared, because we're having 100,000 visitors and we are having 56 countries. Commonwealth teams were coming and they were coming with their own doctors, with their own rules and regulations. And that was my job, that to work in collaboration with those 56 countries and to make sure that our emergency planning services are up to scratch and sitting on the gold command, working with the all blue light services to ensure that we are ready to deal with any incidents. And thank God there was no big incidents happen.
Yeah, that's so interesting. It sounds like a massive job to me. I wouldn't know where to start with that, but so interesting to prepare for an event like that.
But interestingly, then we competed against many other countries for 2012 London Olympics. And I vividly remember that 2 countries went into the final. International Olympic Committee have got rigid criteria against which they can judge the city which is going to host the Olympics. And one of the chapter within those criteria is health. So we were against France, right?
Yeah.
Paris, against Paris. Of course, Paris subsequently won it for 2024. And at that point, the Department of Health and my colleagues in London, they were very keen to use our experience from Commonwealth Games. So I was very lucky in a way that I was able to offer my knowledge and experience from Commonwealth Games, and that went into our bid. And I can't claim that because of that input we won it, but at least I can proudly say that me and many other colleagues played a part, and we delivered an excellence 2012. And I think on concluding remark on this question, crowd medicine has become now a big specialty or big discipline now. Because I remember we were working very closely with police on the Manchester United games. The 80,000 people were coming to the stadium, and you know that it is Manchester City, and the same in London football. But then with Commonwealth Games, we started, before that we had the European football in 96, then Commonwealth Games, and then globally, the big Hajj event happening in Mecca. We learned a lot that they are doing a big crowd medicine because they're having millions of people within 5 square miles, and they deal with all the health needs of those millions of 4 to 5 million people. And this is now a specialty in many countries, the crowd medicine. So I had already got a glimpse of it while doing the Commonwealth Games, because you're dealing with the crowd medicine, you're dealing with many other things. But crowd medicine is something we need to be considering now in the future.
Yeah, I think actually this discussion with you has been a really good example of public health medicine being an incredibly broad speciality, from crowd medicine to the digital health side of things. You're really interesting. Thank you so much for taking the time to talk to us. That was fascinating and has given me, lots of food for thought. So I really appreciate it. Thanks so much, Prof Adil.
If you enjoy listening, why not become a member of the Royal College of Physicians of Edinburgh? Our membership provides you with access to the RCPE educational portal, the live evening medical updates, and you have options to view the symposia both in person or online. If you would like to learn more about this, please go to the Royal College of Physicians of Edinburgh website.